Hello, I'm Sagar Lonial, and I'm here with Blood Cancers Today, and we're going to talk a little bit about the impact of recent data on CAR T cells and how to incorporate them into your daily practice. I'm joined by two esteemed colleagues.
My name is Noopur Raje. I work at the Massachusetts General Hospital Cancer Center in Boston, and I'm really excited to be talking about the T-cell directed therapies in multiple myeloma today.
And I'm Krina Patel. I'm an associate professor at MD Anderson Cancer Center in Houston, and CAR T is my favorite thing. I'm not biased at all, so thank you for inviting me.
All right, so let's get started with really just some general updates that we've seen at ASCO and EHA around both phase 2 as well as phase 3 randomized trials with CARs.
Yeah, we've seen really exciting data, Sagar, and it keeps getting better. We've had 2 CAR products already FDA approved, and this is based on phase 2 data. So we have ide-cel approved after 4 prior lines of treatment. We have cilta-cel also approved in a similar patient population. What was interesting in our ASCO and EHA meetings this year was data from earlier lines of treatment. So you have ide-cel in KarMMa-3, which was used in patients between 2 and 4 lines of treatment. So a little bit earlier than the KarMMa phase 2 trial. And what was interesting to me is that the data was able to kind of reproduce itself. In my mind, the KarMMa data is very similar to the phase 2 data, although it seems like it's an earlier indication. It's going to include patients beyond 2 lines. And then we saw data from CARTITUDE-4, which is the earlier line cilta-cel data after 1 to 3 lines, which is truly an earlier line treatment data. So again, more data to come, but the idea here is to try and open up the indications for myeloma therapies.
Yeah, no, I think the early line trials were great. They are different patient populations, so I think when people try to compare them, you really can't. As Noopur said, the cilta-cel was really len refractory patients. Most had not seen a CD38, so a different patient population compared to the KarMMa-3, where they were triple class exposed at least. And I think what we found is that most of these patients would fit some type of high risk profile in the KarMMa-3. Almost 85% of patients would fit some type of high risk feature. So it really tells us these patients, we would love to have it before 4th line. But it was great access for our patients who do have higher risk disease and seeing that difference in that PFS. So for KarMMa-3, it was like 13.3 months versus 4.4 months. So to have 5 different standard of care options and you get 4.4 months in that little bit earlier line, that tells us these patients, as they're getting these novel therapies earlier, they still have refractory myeloma already, right? So I think that urgency of let's keep going is there. Still a great option. And I think the other thing was the phase 2 studies. They had some of the long-term data. So for cilta-cel, the PFS of 33 months, like almost 3 years for a relapse refractory patient. I didn't expect that, and it was really great to see that patients could have no therapy during that time. And then I think the other one was the LCAR, the original Legend study that actually showed about 16% of patients greater than 5 years out were still in remission. Those were a little bit earlier line and maybe not as refractory, but that gives us hope that hopefully patients getting it earlier will get a long period of no therapy and maybe one day a true cure.
Well, I wanted to ask you both to put some of that data in context, and you touched on some of these issues about comparisons between trials, comparisons between products. And I actually wonder a little bit about the control arms in both of those. How do you think they performed as you would have expected, better, worse, or were there unique aspects of those trials that I think make them incomparable amongst each other?
So I think Krina brought up some really interesting differences, and I think it's really hard to compare KarMMa-3 with CARTITUDE-4, and I think we need to understand and appreciate that everybody throws that hazard ratio out, right? One is 0.4 something and the other is 0.26. Well, the hazard ratio depends on your control arm, correct? And what was seen with the KarMMa-3 control, it was basically investigator choice, and you were allowed to use carfilzomib in that patient population. It was a slightly later patient population, which is why the control arm had a PFS of about 4 months, which which is very similar to what we saw with some of our real world data. And we can speak to that, and Krina, you can speak to that a lot better. If you look at the CARTITUDE-4 study, Sagar, what you saw there was earlier line of treatment. The control arms were very restricted to a DARA-PD or a PVD containing arm. There was no carfilzomib, and you saw how the control arm performed. You know, they did much better, which is in keeping with the number of lines of treatment they've had.
Right.
Agreed. Like 4.4 months for the KarMMa, 11.8 for, and I think those, they're doing better because they're earlier line patients. But again, carfilzomib, I think, was a big one that we would use in the real world. And then, looking at our controls, retrospective studies like Mammoth and Locomotion, the response rates are 30% for those patients who are triple class exposed. And PFS is, usually 6 months, depending on refractory status, of course, or less than a year at least for even just exposed patients rather than refractory. So I think the standard of care arms did similarly to what we would expect. The 4.4 in KarMMa was a little bit lower than what we had sort of thought it would be.
Right.
But I think the patient population, again, 85% having some type of high-risk feature, shows that the investigators were really trying to get this access for their high-risk patients that weren't going to have really other options left even earlier. Right?
So, I think this is sort of a great introduction to the controversies as well as the data that's been coming out in the last 6 months.